Thank you very much. Just letting everybody settle down. So I'm just going to be talking for about 15 to 20 minutes, and this really is just a snapshot. And I've pulled out two particular things that I'd like to sort of explore really in this context. And one is us recognizing the side effects of all of these medicines. And you'll think that's maybe a bit of a weird thing to do, because really when you see the list, you'll think, well, he's not promoting that, is he? Because, you know, the side effects of these medications is something that we really do have to think very carefully about, and in many respects mimic many of the related disorders that we discuss on a regular basis. And I'm also going to talk about withdrawing and stopping treatments. It seems a strange thing to say, but it's easy to start somebody on treatment. It can be very, very difficult to then take somebody off treatment because of the overall effects that it has on the body. So just to kick off, the good news is that since this morning when I introduced, I haven't lost any of my qualifications or my job. The bad news is I still don't have any commercial interests, and so if anybody out there that's looking, if you're interested, you know, whatever. No, I'm not actually. I'm not. I've got far too much to do. I would actually just like to take the opportunity to really thank all of the speakers that have come so far. I know that we've got a couple that are coming after me. Philip, a very dear friend of mine, and I know a good colleague of yours is talking afterwards. I will be supporting the hedge study after I've spoken here, so I won't be here at the back end of the meeting. So could you just share with me a round of applause for all of our speakers today and everybody... And everybody behind the scenes, our staff, and everybody here at the college that are the machine that make this work. Yeah, no, I know I'm good, aren't I? Yeah, I know I'm good, but I'm not that good, right? Because we can't do any of this without all of that skill and expertise. And you know, you've met some of the team today, but they are really quite incredible, and it's a huge privilege and an honour to work with them. So, right, what am I going to be talking about? So, I think the first thing I'd like to say, and this is very much the same for pain medicines, and I wasn't able to be in the room when Helen was talking earlier, but with both pain medicines and with anti-anxiety and antidepressant medicines, there are actually no studies in HSD or EDS that tell us whether there are particular types of medicines that are better than others. You know, we've not done any clinical trials in these areas, and what we do is we borrow from the knowledge of other areas of medicine. And in particular, we're borrowing from, well, the whole area of clinical psychology and psychiatry. We might be borrowing from fibromyalgia, we might be borrowing from chronic fatigue, those sorts of areas of medicine that have, you know, similarities. So I can't stand here today and show you a series of slides that show the evidence for the efficacy or the lack of efficacy of medicines in this situation for either HSD or EDS. There are no specific studies, so we borrow the general evidence. That said, it's absolutely right that the medicines that are used, that are generally available in the formularies for all clinicians to use, should be offered in the right situation for either a significant anxiety disorder, as I was talking about earlier on today, or significant depression. There are some caveats to that, and that is about making absolutely sure, as you would for any medicine that you prescribe, that there are no contraindications to their use in the first instance, which can include things like interactions with other medicines that the person might be on, known side effects from other similar drugs, either in the same class or other classes. So the opportunity is there absolutely to offer these as an adjunct to therapy to support anxiety and depression. But they should not be the only treatment. We've heard today of lots of other ways in which it's really important to treat these kinds of symptoms, understand them, try and manipulate the social environment that might be driving them, trying to support the medical issues that might be driving them, etc., etc. And you've heard some thoughts already around different types of treatments for things like post-traumatic stress disorder. You'll hear more about talking therapies, about mindfulness, about physical treatments. We've discussed diet and lifestyle. All these things are fundamentally important. They should already be in the list of things that are being offered to support alongside the introduction of medicines. Now, do I believe that that happens? Having said that, no, I don't. I see too often that individuals come into the clinic where none of those other opportunities have been explored, and they've been started on a medicine for anxiety or for depression, and it's not working terribly well for them. That said, I see some people come in and it makes a big difference to their mood or the control of their anxiety. So it is very much a spectrum, but the medicine side of it, I truly believe, should be introduced as an adjunct to the overall opportunities for support and not just used in isolation, unless it's an emergency, right? If you're in the middle of a psychosis, of course, but for the vast majority, this is very much something that is part of our sort of more planned, controlled discussion to explore what may or may not be suitable as part of your care. And the problem really with introducing these sorts of medicines outside of the chance that they might work is that many people then experience lots of side effects. People come into my clinic and they say, well, I'm on this medicine, I don't know that it's doing me any good, and I've got all these additional side effects on top of all of these other problems I already had. And I've got a whole load of new side effects as well, which I didn't have before, and I'm just not entirely convinced that it's doing me any good. Or they come in and they say, look, I've tried that, I'm not going back on that. They've clearly got a history of being quite unsuccessful in tolerating a number of these different medicines. You've also, as I've said before, got to be really cautious about avoiding interactions with other medications. We've talked about pain today. Many individuals will be on different levels of analgesics. These interact with anti-anxiety and antidepressant medications. And the interactions can lead to side effects such as drowsiness, poor cognition, fatigue, dizziness, headache. Hands up all the people that without those pills have had all of those symptoms in the last week. So do you know what I mean? It's got to be a balance between what we're trying to achieve in terms of controlling the anxiety and or the depression, but also the realization that we've got to be careful with these medicines. The other final, if you like, nail in the coffin, that's perhaps not the best choice of words, but is that anxiety and depression medicines can also cause anxiety and depression. Now that's a bit of a rub, really. That's really cruel, isn't it? It's harsh, but it's true. And these are all the sorts of things that as clinicians prescribing we need to be very aware of. I think it's really important for those who are on the receiving end and considering the introduction of these medicines or already taking them, that these are very real potential risks. Okay, so let's just have a look at broadly at the common kinds of medications that might be considered in these sorts of situations. So severe enough anxiety or panic attacks to consider medicines, probably amongst the antidepressant medicines for anxiety are the SSRIs. These are the selective serotonin reuptake inhibitors. And I think many of you would be familiar either from your own personal use of these medicines or from others around you that drugs like fluoxetine and citalopram are in that group. And they can be incredibly effective. Beta blockers can also be used. Propranolol and metoprolol are often used. Now, propranolol is one of those theatre medicines. If you have to work on stage and you're anxious about things and you want to try and calm yourself down before you get on stage, 10 milligrams of propranolol, as long as it doesn't give you any side effects, can just bring you back down to a good place. I had one earlier and I'm good now. But give me 80 milligrams of propranolol, and I'd probably have been on the floor. So they really do have their place, and I'll talk about them a little bit more in a moment. The other group that I think many of you will be familiar with is benzodiazepines, and diazepam is probably at the top of the list of those kinds of drugs. We'll explore that in a minute, because certainly when I talk to my colleagues about the introduction of a benzodiazepine, I get a lot of, no, we can't go there. But actually, if you use it in a very controlled way, it can be very, very effective for short periods of time. So we'll just explore that a little bit. And then there are other agents that might be used, sedatives, perhaps for sleep management, even things like zopiclone might be familiar to you. And pregabalin is in that list as well, not as an analgesic per se, but as an anti-anxiety medication used in low doses. So let's just pick up on benzodiazepines and beta blockers, because I'm going to talk about SSRIs, the antidepressant, when I talk about depression. One of the really useful things about benzodiazepines is they're very, very fast acting. So if we need something that needs, where we need a quick action that we might use on the odd occasion, this is actually a really good class of drug. We use it in rheumatology, musculoskeletal medicine, a lot as an adjunct to the management of pain and muscle tension during acute back pain, for example. But we only use it for a short period of time, a week or so, to try and assist with the muscle tension. It actually also behaves better, likely to be more effective, if you just take it as one-off doses and you take very short courses of it. So just a couple of days maybe, and then maybe several weeks later you might use it again. So using it in a regular way may not give you all the benefit that you need. And if you are going to use it in a regular way, then we would very much want to be prescribing as low a dose as possible, in order to be able to avoid some of the more complicated long-term side effects. Now that said, this is not a good suitable drug for children and adolescents. You also have to think about lowering the dosage because of intolerances that can arise often with other medications, and in particular in the elderly. It certainly should be avoided during pregnancy. And it's also contraindicated in certain other situations, such as severe lung disease, liver or kidney disease. So one doesn't enter into this arrangement lightly. One has to think very carefully about the possible potential contraindications and side effects. And these are the sorts of things that people might experience if they just can't tolerate the drug. Drowsiness, difficulty concentrating, headache, dizziness, vertigo, tremor, interactions with other medicines, and its addictive nature if it's used long term. So you don't really want to be taking this for anxiety or depression if many of these other symptoms are already there and quite florid in your portfolio of concerns, because the potential risk is that this is going to cause more issues. Beta blockers then are also fast acting, so very advantageous for getting that very quick action. They can, however, cause lethargy. They can drop your blood pressure. They are associated, if you use them quite long term at high doses, with nightmares. And some people get closing down of their peripheral circulation. So, if you're a Raynaud's sufferer, you do not take beta blockers, right? It's completely contraindicated. And also asthma, it should be avoided in asthma. The advantage here is that they're not addictive, and also there are no withdrawal symptoms, so stopping them is a relatively straightforward process. So let's have a quick think about antidepressants now, and just to start with a very, very brief how do they work. So for all the neuroscientists in the room, and all the molecular chemists in the room and everybody else, I apologize, because this is 2 lines that's probably related to a squillion years of your work, and hey, get over it. Neurochemical transmitters. These are these very clever chemical messages that are basically passing between what we call synapses, between one nerve and another nerve. And the chemicals, as they pass across, effectively sort of trigger electrical signals and send the message down the nerve. There you go, it's as easy as that. And the common ones that we will all be familiar with, I think, from our reading and talking to each other, noradrenaline, also called norepinephrine in the new terminology, serotonin, and acetylcholine. And essentially what antidepressants are doing is they are either boosting the level of these chemicals within the brain and actually in the gut. I wrote an article many years ago called AI, meant to be sort of artificial intelligence in the gut, because many of these networks and these chemicals are in the gut as well. So you'll often see them used for gastrointestinal symptoms. So boosting the level or prolonging the time that they are around in the area where they're supposed to be having their effect. So in effect, boosting the overall effect. But because of the way they work, they typically take about 2 to 4 weeks to take effect. So very few of these are going to have an instant reaction. You're not going to get the kind of response you're looking for within a couple of days. It's going to take a couple of weeks to a month. And the kinds of agents that are in our list of things that we can try, the SSRIs, so I mentioned those for anxiety, but they're also primarily antidepressants, citalopram, fluoxetine, sertraline. The serotonin and noradrenaline reuptake inhibitors, the SNRIs, and the two sort of most common ones are duloxetine and venlafaxine. Now, duloxetine is also an agent that's used as an analgesic. So some of you may be familiar with its place in the list of things that we use to try and help with neuropathic pain. And tricyclics, amitriptyline, nortriptyline, disulfiram, lefepramine, these are all sort of similar agents. And again, amitriptyline and nortriptyline you may well be familiar with as analgesics. In fact, actually, amitriptyline is probably less used now as an antidepressant agent because there are quite a lot of side effects at high doses, and the SSRIs and the SNRIs are better tolerated. And then there are other agents that fall into other classes, and one of the particular larger groups is the monoamine oxidase inhibitors, and phenelzine and meclobamide are agents that some patients might be familiar with. But here's the list of side effects of antidepressants, and the side effects of them are similar to withdrawal, and this is one of the reasons why one, again, needs to be extremely cautious about entering into prescribing in this situation. I am not saying don't take them because of all of the side effects. There may be a really important reason why they should be prescribed and they should be taken. But if you start to run into trouble and think that actually they're not agreeing with you, these are the sorts of things. Anxiety, depression, poor concentration, acute confusion, hallucinations, sleep disturbance, dry mouth, palpitations, headache, dizziness, nausea, stomach pain, muscle pain, sweating, restlessness, constipation, difficulty passing urine, low blood sodium. It's enough to make you anxious, right? It's a long list, and that's probably not the full list. The point I want to make is they can be problematic, and we need to understand that. The other thing that's important about antidepressants is the whole issue of the dietary intolerance. I'm not sure that many people realize, but most of the pills are constituted onto certain types of chemicals, and in this particular case, there are certain agents that are actually have bound to them lactulose, and so if you have a lactose intolerance, citalopram, imipramine, nortriptyline are agents that you need to be careful of. And gelatin is in some other products. So if for dietary reasons, either for restriction or choice, gelatin is not on your list, then you just need to be familiar with these sorts of issues in terms of choice of medicines. Now, just in the last couple of minutes, coming off medication, very important, because there are a number of perfectly legitimate reasons why you might come off medication, but because many of these agents have got what are called very long half-lives, they take a long time to clear out of your system by half of their concentration of their dose. So if this is the dose in your body, and this is zero, then one half-life is there. That could be days. Another half-life is there from the next one. Another half-life is there. And so it can take many days through to weeks for for the medicine to come out of your body. And I've just realized as I did that, I probably should have done it that way, right? For you, many, many days to disappear out of your body. The exits are over here and up there. I thought I did that quite well. I've flown too much. Reasons for coming off. No longer needed. Obvious, right? But actually, it's not a conversation that's had very often. You know, do you think you need this anymore? No. Why don't we try coming off it? It's not working. Too many side effects. Maybe want to switch and reduce interactions, and also starting a family. So you really need, if this is the case, you need to make sure that you're getting advice from someone who's very familiar with the process. It should be a doctor looking after you and advising you. And you've got to understand the risks that there may be in reducing the dose and doing that too quickly. Reducing the dose or the frequency very slowly as guided is really important, because as I've alluded to, it takes time for different drugs to clear the system. Sorts of withdrawal side effects, just as bad as the side effects that I put up earlier on. I won't read through them because it's too depressing, but they go on and on and on, and they're basically all the things that you might expect of cold turkey, and can be extremely unpleasant for people who do this too quickly. So be very, very careful coming off these medicines. So in summary, medications clearly have a very important place in managing moderate and severe anxiety and depression. They do, however, need to be part of a much wider approach to treatment overall, an adjunct to the other supportive treatments that we've been discussing. None of them are without their own side effects. They all have risk of interacting with other medications. There are different classes that you can offer for treatment, and one class might suit somebody better than another. So just because one doesn't work doesn't mean they're all going to not be effective. Switching or stopping should always be with guidance. Stop a medication if it's not working, but again, with guidance. And if you're going to withdraw completely from these, make sure you never do it abruptly. Thank you very much.
Okay, can I welcome back our speakers, please? It's Phil and Linda here. And Alan, thank you. If anyone has messaged Dr. Hakim directly, he hasn't been able to see them because he's been busy at Hedge all day. So either resend them on the subject or stand up by microphone, because I won't be able to see those messages. Okay, we'll start over here in the centre. Thank you.
Hi. I work as a psychodynamic psychotherapist, so I work with adverse childhood experiences. I also have HSD. And I have a concern in my work about GPs referring clients for anxiety and depression. And because I have what I have, I'm able to work out that some of the symptoms they get are physical and not mental. So the concern is, if I didn't know what I knew, there would be some therapists carrying on with the whole anxiety. Now, I'm not saying there's not anxiety there, I'm talking about specific symptoms. And when I've said to my clients, go back and see your doctor, because that's not an anxiety symptom. I've been doing this 15 years now, so I work out what's what. They go back to the doctor, I say, you need to go back and get a referral to find out what this is. And they find out what it is, and they come back and say, yeah, it's some problem with my stomach, and it refers to EDS or HSD. So I just wonder if you've had those experiences, and how do you get the message through to GPs or any other medic that they're causing problems there by just assuming that their clients have anxiety when they don't?
There we go. That happens all the time, actually. That's really common, and because, in a sense, GPs are not so good with chronic pain, medically unexplained symptoms. With chronic pain, the best that they can do is, often give painkillers. So it's very difficult. So they're always looking for somebody to shed some more light on it. And I think it's our job to think about, okay, we've done an assessment, we think some of this is physical, and maybe it's our job actually to contact the GP, send a letter back, and by doing that, we're educating the GPs. Sometimes I go, where I work in my NHS practice in Kingston, I go to the GP kind of like seminars and I talk about kind of like EDS because I'm just trying to increase their knowledge of it. But in terms of their training, they wouldn't have had anything on EDS. So I think it's, again, it's one of those things where we're slowly educating people through lots of different means, but I suppose we do have to take on the task of actually educating the GPs.
It does work. So absolutely concur. It happens all the time, every day, every clinic. That's that story. And it should work both ways. So if I see somebody who comes in and much of what we discuss is a realization that there are lots of psychological issues and maybe less on the physical, then I should be able to just have a completely normal, mature conversation with somebody from psychology or psychiatry, wherever the support's needed, to say we need some help and we need to work together to, to support this person. So it works both ways. But the thing that I find the most distressing, to be honest, is when somebody is sent to a psychologist or a psychiatrist, and the psychologist or the psychiatrist says, fundamentally, this is not a psychological or psychiatric problem, it's a physical problem. And when the individual goes back to see the doctors, they completely disbelieve the report of the psychologist or the psychiatrist and continue to pursue this avenue of it being a psychiatric issue. And I just do not understand that at all. And that tells me that in those sorts of situations, this experience and understanding of the physical issues is just completely lacking. They just don't have the skills. Now, I am the first person to say it's fine not to have the skills. It is not fine to ignore the fact that you don't have the skills and continue to pursue that pathway. It's completely inappropriate and it's bad for patients.
We've got a long way to go. I've had two experiences of talking in London to the medically unexplained symptom national group and also local psychiatrists. And it's very interesting just seeing how the pennies start to drop when you present the story that we have. And it does mean that we've got to do a lot of education. We do, with the HMSA website, we have a meeting in a box that you could tell your GP about, because what we think, I think we all agree that it has to start with GP education. That's where it's got to be, because a lot of the less severely affected individuals just want a diagnosis and don't necessarily need a lot of intervention. They just want to know, why have I got all these symptoms? So I think the whole issue of somatization as a philosophy for psychiatrists is a big worry.
Okay, question for, yeah. Question for Alan. In using beta blockers, how about using something more specific such as antenolol that is beta-1 specific, easier on the lungs, and does not cross the blood-brain barrier, so it's non-sedative? The idea would be to break the feedback mechanism of perceived increases in heart rate, increasing symptoms of anxiety further.
So who's been reading up on their beta-1 and beta-2 biology? Well, no, I mean, absolutely. I mean, atenolol is in there on the list. Agents like metoprolol and bisoprolol are often used because they're actually better tolerated for the various types of side effects that they can be. But there's no reason why you can't use atenolol as a perfectly reasonable beta blocker. They've all got beta-1 activity, and the first two have got some beta-2 activity. So I don't know who asked the question, but it's perfectly reasonable to use atenolol. Thinking about agents that are used for beta blockade to control blood pressure in things like vascular, EDS, metoprolol and bisoprolol and celiprolol are the sort of more typical ones to go for because they've got much more multi-receptor activity.
Thank you. And this is not a question but a comment that some people may find helpful. In addition to the BACP, the professional body for counsellors in Scotland is COSCA, Counselling and Psychotherapy in Scotland, and they have a list of accredited counsellors on their website. Okay, bear with me please while I just go through the questions. Oh, hello, there we go, go on.
Are we there now?
Yes.
Can I just say that it's not very easy to stand up here and make this comment, but I'm going to do it anyway because there is a purpose for me, the same as everybody else, to be standing here. I want to put to the panel just exactly what's your opinion on trauma induced by professionals to families out there that are struggling to get any help and support. I was in a position myself after 9 years of looking for assessment for my son, who did turn out in the end to be autistic, and it turned out that my other 2 children were also autistic, and I've been diagnosed myself. In the process, 4 years ago, I went through a traumatic child protection situation where it was assumed that it was my mental health that was the problem. And I've spent a long time trying to understand and comprehend how people can be put in the position that we are as parents when we are trying to get the best for our children, and now in a position that are frightened to do so because of things that have been done to us in the past when, you know, we've been in a position that we don't know how to handle it. You know, I can be quite an articulate person, but I'm better writing things down than I am addressing things face to face. So I really want to put the question to you that there is families out there that find that they're completely in a position of being soul destroyed by prolonged outside agencies who appear to conspire but don't take ownership when proved wrong. Now, I was in that position and did nothing about it because I have no strength left anymore. All I wanted was an apology. I never got that. But I'm now in a position that all my autistic children show signs of hypermobility. And I'm in a position now that I am terrified to take it further because am I going to be subject to more stress? You know, there's kids out there that are suicidal, that have taken their lives because of professionals, and there needs to be a time that this stops. People need to start listening to parents, you know, because at the end of the day, we know our children better than anybody. That's my little sorry.
So absolutely, and you know, on the positive side, there are also doctors like this, and I think it doesn't excuse that, because there are terrible, harrowing, unforgivable things happening to families out there in the UK and all over the world. And this is an opportunity to mention that we are actually bringing together a round table of experts that will be meeting at the Royal Society of Medicine in London in April, that are focusing on the paediatric issue that we are seeing all over the world. We're bringing together policymakers, members of the International Consortium, and members of the Pediatric International Consortium to try and tackle this head on, because it's not good enough. We need to make a difference. We're taking that challenge on, and we want to work together with everyone to try and make that better.
Terrible trouble with buttons here. I'd like to, we're recording this, right?
Yes.
I would like your permission, if we may, to actually use the way you've asked your question today and to take it to this meeting as one of the examples of a real story with real compassion behind it. And I'd just like to, we'll check afterwards with you if you're all right with that, but I'd like to really thank you for asking that question. It's so pertinent.
I suppose in the meantime, I think, yeah, the way you asked that question was absolutely great. So I'd almost start there and think about going to your GP. And I've advised lots of people to do it. If you don't feel that your GP is helpful, unfortunately, I've had to ask a lot of people to try and change GPs. But really, if you can find one health advocate who is on your side who can understand, and try and get that person to do as much as they can within the system, that would be really useful. I know that's not easy, but that's just one thing that you can do in the meantime before all this other stuff comes out.
So I have with that kind of depressing notion of that's going out there, something that is inspiring of someone that's tuning in saying, I work as a physiotherapist and I want to help these patients live a healthy, active, independent life. I often struggle to manage patients' expectations of what we can and cannot do. When I ask, many patients tell me they want me to take their pain away, or a doctor has told them they need to go to a gym. This must be terribly frustrating for patients. How can we as healthcare professionals better manage patients' expectations of treatment options for EDS and HSD? So there are people out there willing to help us, which is great. Can we have an attempt at an answer on that question?
Well, I think we are, aren't we?
So how can healthcare professionals better manage a patient's expectations of treatment options for HSD? And your advice to a fellow professional?
Better manage the expectations. Well, I suppose the first thing is to have a conversation with the person that you're working with, your patient, as to what their expectations are. I think we spend a lot of our time looking at the current functional issues, various symptom profiles, thinking about our own expectations of our own interventions, goals to be set. Are these goals realistic over a period of time? What are the more long-term goals? So I think if you don't start with those sorts of conversations, it can be quite easy to go a long way down a pathway and have realised that you've never actually set a set of expectations. I wonder actually whether how many people in the room have gone into the room to a clinic, to a consultation with no expectation. Hands up if you've gone in with no expectation that anything was going to come out of it. Yeah, so it works both ways.
There are a lot of hands up.
There are lots of hands up. So work with your patients to identify the expectations and be honest about what you feel you can and can't provide. And equally for patients, everybody in the community, have in your own mind what you feel your expectations are. It's okay if they're under, because if we think we can do more, we'll try and boost you. It's okay if they're over, because if they're over, we need to have a conversation and bring them back down to something that's a bit more realistic. It doesn't matter either way, you've just got to have the conversation.
Absolutely. Is psychotherapy still useful if the patient has little childhood memory?
Yes. Yes, because there are ways of finding the memory. So using EMDR or EFT, there's ways of finding that memory. I haven't talked about it here, but also to some extent, hypnotherapy, you can find the memory. However, finding the memory is not necessarily so important. It's working with the present symptoms. So in the absence of the memory, what are the present symptoms? And are there any other memories that can be remembered that feed into the problem? And so with the CBT approach, you're always trying to work with the here and now. How can the person cope in order to relieve their suffering and distress in the present?
Yes. Thank you.
Yeah, hi. Briefly, my work background is in mental health, and both as a nurse and as a social worker. 30-odd years ago, I had what was thought to be a very minor accident, and went to see an orthopaedic surgeon. I was told, can you bend over, touch your toes, Yeah, no problems. I mean, by this time I was experiencing severe pain. I couldn't stand for more than about 5 seconds without blacking out. As I said, saw this orthopedic surgeon, was told, asked, can I bend over, put my hands flat on the floor? Yeah, piece of cake, no problems whatsoever. The report that I got from the orthopedic surgeon said any pain this woman thinks she might feel is probably a psychological reaction to her husband's death, coupled with a little bit of paramedical knowledge. As a result, I lost my workplace pension. I had to give up work. Sort of 35 years later, it's still impacting on my life because of the whole financial thing. And it's just this whole transition from being a respected mental health professional to just becoming this woman. And it was just an incredible experience. So yeah, just wanted to sort of share that it's not always good.
No, it's often not, and I'm afraid that I still see people in clinic who come with those sorts of stories. And there's a couple of things that come to my mind in your story. One is this perception that somehow because you can move apparently more than normally, that you can't have sustained an injury is nonsensical. Equally, we were talking about earlier on today how you can dislocate joints and it not be painful. People who've got very unstable joints can dislocate their joints and it's not painful.
I had an L4-5 rupture.
Right.
But it was painful rather than natural.
So there are all these misconceptions around how pain and the mobility and the impact on function somehow should both track with each other. High levels of pain, clear evidence of reduced function. But the other thing that I do, somebody who has that kind of story, is ask the question, who wrote those things about actually formal, correct assessment of the diagnosis that they made and the statement that they gave, so that there was formal evidence that they'd worked this through. And I have to tell you that the vast majority of the time, the answer's no, they did not. And I have cases where people have been given various psychological diagnoses and there has been no formal assessment by that individual. I love my orthopedic colleagues, but I doubt very much that any one of them would ever have the time, and very few of them would ever have the knowledge to do a formal psychological or psychiatric assessment in that way. The problem is, at the professional level, when that's down on a letter by Mr. So-and-so, who's a very important person in the local hospital, we're in trouble. And right now, I spend my time getting those statements off people's letters because it leads to the kind of trauma that you've just described.
Hi, it was 2 questions if there is time. The first one was to do with the gut and the psychological and emotional health, what we eat, how our diet can impact on that. It was just to get the feedback from the panel and what they think on that.
Yeah, so this really brings us back, I think it's working out. This brings us back to the issue of the microbiome. And everybody's got a different microbiome and everyone has a slightly different reactivity to different foods. So it's a very complex area. I think it's true to say that we're just starting to understand it. So it's breaking news, really. And I think you'll see a number of the speakers that come to the Ehlers-Danlos Society, but even back in Ghent, we had a speaker go into great depth about this, and that's available, I think, for you to look at. It's incredibly complex, and we're only just starting to unpick things like celiac, carbohydrates, all of the mast cell activation, all of these things it's exciting times for those who are academic. It's not so good for people who are right in the middle of it, working their way through. And I think it's true that most of my patients work their way through to some kind of tolerable existence. But it's very, very difficult. And you never know quite when you're going to bump into something unexpectedly that's going to knock you out for days. So a very good question, but no simple answers.
At lunchtime I noticed there was about 1/3 approximately that were for the special dietary requirements. So I don't know if a lot of people are figuring it out for themselves, that it's maybe having an impact. But the second one, if that's okay, was about time management. It was slightly touched on. If this is an actual problem within people, within the EDS community. I noticed again there was a lot of late comers, and I'm notoriously late. Everywhere I go, I'm late. I'll normally try and laugh it off, but it's embarrassing and it causes a lot of problems. But it's really whether or not this is like the actual physical challenges of the condition, as it's constantly changing. One day it takes 10 minutes to have a shower, the next day it takes an hour. It's managing the time that way, or is it an actual condition of time blindness? It's just to see what the feedback on that was.
Yeah, I would say the time management problems seem to be universal. My experience of this particular population is that time management does tend to be related to physical mobility and physical limitations, trying to get around. So while we can think about time management, particularly for people in relation to their work, from my experience, it doesn't necessarily, it can do, but it doesn't tend to come up much deeper than that. Because it can go back to your childhood, but it doesn't tend to go much deeper than that in this population. So from my experience, it does tend to be because of the physical limitations around the body.
That's great. It's a relief to hear that. Thank you.
Hi, sorry. I think one question I'd like to ask is, I think a lot of people here would have spent a lot of money in the end trying to source the right doctors for their conditions. And it's knowing when to stop, when to actually realise that actually we're not going to get any further with the NHS at the moment, and we need to take this in our own hands and take a bit of ownership until we can then move everyone forward and bring everyone together. And I was wondering, have you got any advice what the best way is to collaborate everyone that you're trying to work with together?
Bring everybody together. As somebody who's worked in the NHS for many, many years and now works privately, I have huge amounts of sympathy with regards to access to people, and we see this both within the doctor side of things, the therapist side of things, pediatry. There are certain types of techniques that aren't even available on the NHS, right?
Two pain clinics. 2
pain clinics. So it's a very real phenomenon. One of the pieces of work that we've been trying to do as several groups, HMSA, EDS UK, the work we're doing with the Ehlers-Danlos Society, is at multiple levels work with the NHS to try and improve the understanding, the commissioning of services. So at one level, we're right up there talking to very senior commissioners at NHS England. At another level, well, let's not call it levels. In one place, we're talking to commissioners about how we improve services. In another place, people like Philip are going around Kent and educating and training and bringing networks together. We have the ECHO program that we're running, which is this all teach, all learn education program that anybody can jump onto from anywhere, whether they're NHS or private, it doesn't matter. We have masterclasses running up and down the country. So these are all ways that we're trying to sort of facilitate the development of much greater skills within a multidisciplinary team. Does it take a very long time? Yes. Even in the private sector, Professor Graham's still here, it took an extremely long time for us to gather our network together. But we had to start somewhere. And we're working closely with colleagues all over the country where they may be the catalyst for something. Philip was the catalyst for something in Kent. Maybe just sort of share your experience of what's happened in Kent over the last couple of years as an example of what can happen.
Yes, I mean, I've probably spoken to about 1,000 health professionals in Kent, including 200 GPs, and we give them this clear sort of outline of the questions you need to ask, the things to look for, and the simple things that you can do in primary care, like, you know, if you've got POTS, take more fluid, more salt, simple things that make big differences, and things like mindfulness, things like Alexander technique, which we have got in our pain clinic. We've got Alexander teachers there, and kind of increasing the toolkit. And all 3 charities have been enormously helpful in allowing us to say, right, go and look at this, or there's this conference, come to Ghent, you know, whatever it is, it's out there. One thing I did want to say about medical progress is that Alan and I have been through a period of time with a different condition known as rheumatoid, which we've got much greater understanding about. When we started, certainly when I started in 1980s, there wasn't really an effective treatment for an incurable condition. And at every clinic, you would have 3 people in wheelchairs who have just had totally destroyed joints. The picture has changed over my lifetime in the NHS to something which is now eminently treatable. And although we don't know enough about this condition, there is cause for optimism because so much international understanding is and research is going on that I think there is cause for optimism for the future because things do change in medicine.
And I think to build an army, you need 1 or 2 leaders. And everywhere that we've been, where we have successfully started to develop programs and networks, there's usually been 1 or 2 people who have been catalysts. And they might come from doctors or therapists or other people. So if you know in your area of people that are sort of in the thick of this, but don't have a lot of support around them, that's where we were 10, 15. That's where colleagues are now. It's okay to start somewhere with very little and build. And one of the opportunities that we now have with the way we can network using virtual groups and everything else is that is so much easier to do in terms of having conversations with each other. A colleague of mine took a masterclass on physiotherapy up to Northeast England last week, 2 weeks ago, when we were at a staff meeting, and she ran a full program there. Fantastic. Loads of people there that were grappling with all the sorts of things that we've been talking about today. And I dialed in from 5 hours behind on the east coast of the States and joined in, and we all had a really good conversation. These things are easily done. It just requires people locally to have an interest. And if they're a catalyst, get them to contact us.
I just want to say thank you because I think it's about pulling the whole families together. We've talked a lot today about patient having that psychological support, but I also think it's very important for our partners too as well, because they're not just dealing with one, they could be dealing with children as well, and this up and down of the ADHD type of symptoms as well on top. And I just want to say thank you for the whole day anyway.
Thank you.
Off the back of that, I just wanted to ask, as we're here in Edinburgh and this particular country has a pretty poor demographic of EDS clinicians, is there any advice you can give to patients in Scotland, specifically people who are desperate?
I would say one piece of advice that I would give to anyone in Scotland and anyone listening from all over the world is tell the professionals, your GP surgeries, about EDS Echo that we've set up. Because that was set up to create 1,000 EDS experts by 2022 by this all teach, all learn model that's free to take part in. People can dial in from anywhere where they are in the world, present their de-identified case studies that could be people like you sitting in this room, to talk to experts to find out what the best care is for those people. And through that process, that's how you create more experts, because there's actually no such thing as an EDS expert. Doesn't exist. You have rheumatologists, geneticists, gastroenterologists, and on and on and on. And they are individuals that have taken an interest in this condition and been willing to educate themselves. And that's all we need, all around the world, more and more, because we still have a small collection of these experts that have dedicated their careers often to this condition, and for that we're so grateful, but we need many more. And everyone can help us do that and build that army of experts, because it's not impossible. It just requires their willingness to learn.
Yeah, can I tell you a little story about somebody who was brave enough to come down from Scotland to see me in Kent? And that initial consultation, I was able to kind of outline certain things that she needed to do. And I know that Julia has seen her. So she's had some Alexander lessons in Edinburgh. I then reached out to my gastro colleagues, because that was a big thing. I said, who do you know in Edinburgh who could deal with this? And so, so there was just 2 examples of kind of remote control, and she's doing really well. I think as our network increases, and a similar story from a ballet dancer who came to me who was going back to Madrid, or was it Barcelona? And I said, I know somebody in Barcelona, there's a professor out there, and we were able to plug that individual into the hypermobility network in Barcelona. So it's networking that I think makes the difference.
Yeah, absolutely. I can't do this afternoon.
That's it.
I've got some kind of motor dysfunction. Absolutely about the networking, and we're growing and growing that network, and part of the work that we're doing is extending the kind of international consortium with all of the expertise, and it's incredible once you do know. Sometimes I feel like a Yellow Pages. So people will come down to me in London and they'll say, you know, how are we going to do this? I actually already have many contacts. What I can't understand is why those contacts don't know each other locally. And I think one of the things that we need to try and do is get them networking closer together, however we can facilitate that. So network. We do know the people. I know there are people up here because I'm referring people back up here all the time. But the other piece is the whole conversation with NHS Scotland and commissioning. And some of you will know from last year that this conversation did start, and NHS Scotland was looking at some of its data, which is the information it has on patients that are being transferred down to England for assessment. And I know that conversation is still happening. I did promise a couple of people who asked me a very similar question earlier on that I will email the colleagues that I've been in touch with, because they've spent time with me starting those sorts of questions, and it was one of those catalysts. So this isn't a clinical catalyst, this is a service delivery commissioning catalyst, and it started. It will take a long time, I have no doubt, because these things do. But there is this kind of undercurrent of work that's going on.
And to remind you all that we do have our medical directory, and we do have people from Scotland on there. So it's worth checking that out and seeing if there's anyone local to where you are.
Can I just add as well, if you're in sort of this area or north of England, we're very happy, and if you're interested in finding out about the Alexander technique, we're really happy to organise some workshops for people to get together and find out what it's all about.
See, there's a lot of people willing. You know, when we published the 2017 criteria, there were 90 people in the consortium. There's now 140. That's just in 2 short years. So it's growing. It is changing. We've all got, as a community, PTSD of this whole process of 20 years of no updated nosology, no real research, no funding. You know, and there is hope on the horizon now. It's just going to take a really long time to repair that damage that was done over such a long period of time. I've got time for 2 very quick more questions. So up there and then to the middle.
Hello. So I have a question regarding children. I have EDS myself. I was diagnosed 3 years ago. Recently, my daughter has displayed some symptoms, which she was referred to our local rheumatologist at the Sick Kids in Glasgow. They said that she was a normal, healthy girl with nothing wrong with her, even though her collarbones dislocating, her shoulders, etc., other things. So I took her to see Professor Chikanza in July of this year, and she was given a diagnosis there. Going back to the GP, from seeing Professor Chikanza, he had asked for some specific tests to be done on my daughter, some extra bloods. And the GP, after seeing him and read the professor's letter, he said there was a marked contrast between the local NHS rheumatologist and Professor Chikanza's letter, and that if I didn't mind, could he re-refer her for a second opinion. We were there yesterday, and again we were met with the same sort of attitude that she was quite normal. They agreed that she did need physiotherapy of some sort, but they said that there was a whole buzz, was the correct word, around EDS at the moment, which obviously is what you're trying to create, is a buzz and an awareness, which we all know. But she said that she was unwilling to acknowledge that she had EDS. She didn't think she had it. She wasn't going to label her with anything. She didn't believe in the Baton score assessment for children. I'm aware of the statement that came out from the British Society of Rheumatologists. I know that there was a letter sent back from yourself and EDS UK. So really my question is, does anybody know why there's such a reluctancy to diagnose a child, and why there seems to be this problem that they don't have anything wrong with them? Because today's all about the psychological and emotional health, and I feel that telling a child that they're perfectly normal, when my daughter's had to give up a dancing career, etc., she can't do certain things, what does that do to her mental health, to say that she's normal? And we don't have any services available. On one of the letters it was written that I had a shopping list, and that they were worried about me trying to get a medical diagnosis for her. So as again, we come back to the sort of child protection sort of issue. So it was really just to see whether anybody knew why the NHS rheumatologists are unwilling to address this.
Yeah. I think it is a real problem. I think it's probably the case that a lot of children who are hypermobile, that it goes away by the age of 14. That's what the paediatricians are saying. And that group who don't go on to get anything more complicated could be reasonably reassured. But the problem is, how do you know when it's an 8-year-old which way they're going to go? And Alan and I spend a lot of our time at the end seeing 25-year-olds who've had clues all along the way from that kind of pediatric contact, and then an orthopedic contact with subluxing kneecaps, and then an irritable bowel consultation with a gastroenterologist being fully investigated, and then all the way on the background there's been something suggestive of mast cell activation, and then they end up with us. So looking back, it's easy to say, well, why couldn't anyone have put this together? And I think that's a lot of what we're trying to do, is get the adult specialist at least to see those links. But with kids, it's another story. I've got 2 grandchildren, and my daughter-in-law is very hypermobile, and my grandson, who is 3, is not at all hypermobile. But my granddaughter, who is 1, is extremely hypermobile. Now, knowing what I know, I'm not too worried about her because she's walking and she's really active. And I suppose at the moment, what we're trying to do is say, don't protect those kids to the extent that they don't participate in exercise. Kids do better when they do more. But it's a very complicated area, and we don't have the answers. And you are right that some of our paediatric colleagues don't quite get it right. I've got one paediatrician in Kent who doesn't believe in POTS. Where do you start? It is complicated.
Absolutely. I mean, I think so. These are definitely other areas that we want to explore when we start our rounds of discussions with our paediatric colleagues. But we also have paediatricians, paediatric general physicians, and rheumatologists in our consortium, and we are exploring all of these areas very much. And the message that I get across, that comes across to me from them, I think time and time again, in particular, is in the younger children, typically say up to the age of 9 or 10, it can be very, very difficult to be clear what the diagnosis is, but that should never stop you treating whatever the problem is. So treat the problem, not the diagnosis, is a sort of way forward. And I can see the sense in that, because it can be very difficult to know whether a younger child will go on to fully develop many of the features of, say, hypermobile EDS, as opposed to the functional issues in the there and then, which may be very physical, which would be very typical of themselves of hypermobility spectrum disorder. But actually, if you spend your time almost concerned about the diagnosis and don't actually clock that you've got a youngster in front of you with a set of symptoms that's having a functional impact, then you've kind of missed the point, because this problem doesn't go away. Now, the other thing just to bear in mind is that actually we've had, so the British Society for Rheumatology has revised its guidance that it wrote in 2013, and that came out very recently. And broadly speaking, it's useful. It's got lots of very sensible suggestions, and it would be good to see whether those suggestions have actually been worked through to be confident that actually the whole assessment's been done. The other thing to bear in mind is that the College of Pediatrics and Child Health has actually endorsed the 2017 international criteria for a diagnosis of hypermobile EDS. So if the signs are there and the diagnosis is endorsed by going through the criteria, then that is the diagnosis. And the issue that you then have is you're possibly working with somebody who doesn't know that level of knowledge. So it's a knowledge gap.
Okay, thank you.
Okay, thank you.